registered for this webinar today on various platforms, I really want to start by saying a very, very big thank you, because that support is what makes this webinar absolutely special. And when we started, the whole purpose of this webinar was not just to support primary care, but to develop a much wider understanding of the fabulousness of the trials, of the challenges, of the tribulations, but also an understanding of the greatness some leaders in primary care have been silently bringing and ushering in this era to deliver great care for us. Folks, good evening. I'm Mohit Venkatram. I am your host for the Future of Primary Care webinar series. And I recall years ago, it's been years now, when I visited a practice as an inspector, and I was being told by some amazing staff, people who were so warm about what they were doing to support the challenges their residents were facing. What intrigued me, though, was that when I visited other practices, many of them had already cracked that nut. And you sit back and reflect how great it would be if we could share the good practice with each other in such a way that our patients, our residents benefited. And it was with this view and my philosophy of why invent a wheel when it already exists that I developed the concept of the Future of Primary Care webinar. And it started, I recall, with a handful of people. And we attended for some time, and people gained traction, and the webinar grew in popularity. And I was just toting up the numbers, but last year, just last year, in the 12 months that's gone past, we had slightly over 3,000 people work and learn together on this webinar. That's the number of people who registered, who watched the webinar, looked at the reruns, and you sit back and reflect in that glory, thinking, this is absolutely wonderful. I've put in a lot of personal time in developing and leading this. And I feel pleased when it comes to fruition, when it actually makes a difference and really changes the lives of many of us as residents and many of us as clinicians, so that overall the care improves. Many of you know I am the Deputy Chief Exec of Northeast London Foundation Trust, and as an organization, we have a strong view that if we worked really closely with primary care, hand in glove, and used our resources like we are doing in supporting this webinar, then that vision would help us deliver some amazing care for our local populations. And as an organization, we serve a very, very large patch. There are almost 4 million people served by Northeast London Foundation Trust. And so sharing our resources makes absolute sense. Of course, as you know, the NHS is also moving in that direction. It's yet to be seen if other trusts, if other organizations follow the path and the vision that NELFT have been pioneering now. I'm, of course, pleased that the time and commitment is making a difference. We always spend some time in the beginning of these webinars reflecting on the achievements of primary care in the months that have gone by. Some of you may know that the data for June 2025 of the activity that has been done in primary care has just been published. And believe me, there is no other way to start the numbers and share with you the activity without saying Drum rolls. In 1 month alone, all the GPs, all the primary care services, all the PCNs together saw over 31.5 million appointments. I'm going to pause at that number. It is absolutely incredible to know, as a group of clinical colleagues, their delivery has been just magnificent in the month of June alone. Unfortunately, only 90% of those appointments were attended by us, and a part of me does think we have to take some responsibility as residents, as citizens, because if 90% of appointments were attended, about slightly over 3 million appointments got wasted in the system. And that would have pushed the numbers way higher in terms of achieving the outcomes we would like to see. Just under 45% of the appointments were same-day appointments. 45% of the appointments were done by the GPs. And then a number that often many of us talk about to say, were they face-to-face appointment? Did we find it meaningful enough? And over 65% of the appointments that were delivered were face-to-face appointments in the month of June. Now, for those of you who, like me, like reading the health journal information and the articles that get published, what is really the part that gets to me is the fact that evidence shows 25%, that is 1/4 of the estates, buildings that are occupied by GPs are not good enough. Despite that huge challenge of not having good premises to see their patients, they still delivered over 31 million appointments in that 1 month alone. You do want to sit back and say, it is such an absolute wonder that we have such passionate colleagues, and absolute hats off to them, because together what they do is phenomenal in improving care for our residents. Many of you will know that the latest initiative of providing good care is all about the development of neighborhoods. It's about working together with other colleagues. And through the neighborhoods, it is a way of having geographically aligned services working together with primary care and wider services that exist. But for every change in national policy, for every change that is rolled out for others to follow, there have to be pioneers, people with vision, people who saw what was right for the residents, for you and me on the street, and saw it years before anyone could even think of it. I am so incredibly pleased that our guest today is one such amazing GP who had articulated the vision that is being rolled out as a national policy way earlier and has been piloting this, whose learning has helped us move this forward in a way none of us could have done without. Our guest today, Dr. Deborah Gompertz, is one of those really, really amazing GPs who has complex care GP background. She's been the clinical lead for the whole of complex care in South Somerset. She's led on the Vanguard project set up in Somerset. She has worked in A&Es. She's been a partner for over 20 years. She's been part of the NHS England Clinical Entrepreneurship Program. It's one of those GPs, if I started setting out all her accolades, all her achievements, I'd probably be breathless. So it suffices to say She's one of those GPs who, if she was not there, probably in today's world, the whole of primary care in this whole country would have been poorer. So I am just so glad Deborah kindly gave us time today to share her vision and her experience of what she's been doing. Deborah, a big welcome to you to this webinar series. And before I hand over to you, just very briefly to remind colleagues, you will recall with over 200 of you registering for this and being on multiple platforms, it's nearly impossible to open up a conversation with everyone. So you have the Q&A button on the Zoom platform to use. If you want to post your thoughts, post any questions, please do so there, and I will pull out the themes from them once Deborah has had a moment to share her views with us. Deborah, welcome to the webinar, and thank you so much for your time today.
Thank you, Mohit, for that very, very kind introduction. Can I have the first slide, please? So first of all, I'm going to introduce myself. My name is Deb Gompertz. I'm a GP and I work in South Somerset, as Mohit said. I've used to work in hospital medicine and I have worked in A&E. I am a clinical entrepreneur, as Mohit says, and I'm also the Deputy Honorary Secretary for the British Geriatric Society, soon to be the Honorary Secretary. I'm a member of the National Association of Primary Care as well, and one of my passions is prescribing. With all of this, though, my key part of me is being a GP and looking after people. And that's what really drives me and inspires me to get it right for people and to look after the team around the people. So I currently work with 4 what we call integrated neighbourhood teams, and that involves 4 primary care networks, for those of you that don't know exactly what an integrated neighbourhood team is. And an integrated neighbourhood team is about 30 to 50,000 patients, to give you an idea. So I'm going to talk to you about cross-organisational, multi-professional teams. I'm going to talk to you briefly about the structure of how I work, but I'm going to keep it simple. There's so much information about neighbourhood teams out there at the moment on LinkedIn, and they're all quite complicated with language that I don't even understand. And actually, I just want to say it's not complex. People are not complex. We've made the system complex. We've got to keep this simple. It is purely about people and talking to people and listening to people and making friends with your colleagues. And that's what I want to get across to you tonight. And I'm going to talk to you about how I think we achieve that success and what success looks like to me, because it may look different to you, but what it looks like to me. At the root of all of this are the people that we're looking after in the community. So why is neighbourhood working important? It's about the communities that people live in, and it's how we support people in whatever area, whether that's rural or urban. People will have difficulties and differences, and people do not always fit a pathway that the NHS says. So we have to think about that no one fits into a box. So we have to be able to broaden what we do and sort of blur the boundaries and the edges to look after people as they are and see what matters most to them. And that's the important bit, so that they feel that they're in control and ownership of what we're doing. Can I have the next slide, please, Fran? So this may look a little bit complicated. So I just want to give you the basics of where I sit in the geography, because I think that's helpful to understand what I do. So I do work with 4 primary care networks or integrated neighbourhood teams, and the population size of those 4 is about 180,000, much, much smaller than the London areas. But primary care network neighbourhood team is roughly 30 to 50,000. For the purpose of this talk, I'm going to talk about one integrated neighbourhood team that I work clinically in. So the one neighbourhood team, as in the orange yellow box, I'm colourblind. I'm going to just announce at this point. So if I get the colours slightly wrong, that's because not intentional. So the population I work with is 36,000 people. That's 5 GP surgeries, and I'm in a rural area, to give you an idea. So those 5 surgeries are set in quite a large geography, and I can drive 45 minutes from one end of my patch to another. There isn't a hospital in our patch, so it's a long way for people to get to a district general hospital. So I live in a community hospital, and that's not because I work in it, it's because the district nurses, the therapists, the occupational therapists and the physios and the older person's mental health live there. So we very quickly moved in with the teams that we felt we should be working with, because then you get the conversations. You all realise you're working with the same people, and you realise that you're duplicating work. And actually, you can find that 3 people will be seeing the same person in the week. And actually, if you work better together, you can have a bigger, better team. On my caseload at any point in time, I have about 80 people. Our integrated neighbourhood team has over 300. So that includes the district nurse team caseload, therapy team caseload. So we're looking after a lot of people between us. We get 30 referrals a week approximately, and that's to the whole team, but we blend our referrals so that we can look after people together. Referrals will come from, as I'll talk to you a bit later, referrals can come from GP practices, hospitals, community teams, people, patients, families, carers, anybody. We don't have criteria for who's referred to us apart from 18 and over. Our population is generally older, but as I said, we do see adults. We have IT, or we have access to 4 IT systems, but in Somerset, we're lucky that we have something called CIDR, not with a C, but with an S, Somerset Integrated Digital Electronic Records. So we do have a platform that we can all see across each other's information, and we do have shared forms on that platform as well. So resuscitation forms can be shared, so there's one version of a form across a county for a person or a patient. My team that I work with is complex care. That's me, a nurse and an assistant practitioner. However, I don't see that that's just my team. That's how we started off. I'm also part of the 5 GP surgeries, and though I'm not actually employed by them, I'm as much a GP in those surgeries as any of the other GPs. I also work with the community services. They are now merged with the acute trust that I'm employed by. However, that's not how we started 9 years ago. We were all very separate organisations. And something we don't do is identify with our employers. We identify with the people that we're looking after very clearly. We do also have a team in the acute trust of 3 people, 2 nurses and an assistant practitioner, who we link very closely with when our patients, people go in and out of hospital, so that we are making sure people get what we think they need or in fact don't need. So, and sometimes we want people kept in, sometimes we would like people sent out, but with some investigations before they're sent out. We have a wider team of an Alzheimer's support worker, voluntary services, social care do live with us 1 day a week. So we have built those relationships, and I'll come on to that. The building blocks of what we do are our multidisciplinary teams meetings. So we have a structure over the week that we meet with each surgery once a week. That can be from 15 minutes to an hour. It's normally on Teams, but prior to COVID, it was always in person. And it is so important to meet people in person to build up those relationships. So even now, when we're travelling around our area, we will pop into surgeries to keep that connection going. You have to work at relationships to keep them live, so people know what you're doing, who you are, what you're achieving. So those MDTs that we have a slight structure for those. We talk about people, the surgery doctors or staff anyone are worried about. We talk about people that we've seen for them. We have admission and discharge data, so we have that every day, so we can talk about recent discharges that we're concerned about or people that have gone in. We can also do project work, so we can talk about artificial intelligence patients that have come up on a list, maybe highest complexity, most likely to go into hospital. We can also talk about anything that we want to do a project on, so like housebound people on 10 or more meds. We think of our own projects. So we did one a while ago on showing people's medicines in the homes to identify medicines waste. So we can put that into a surgery huddle, and we can stratify the workload across the MDT. So we don't do all the work. It's stratified to the right person. It may be a health coach in a surgery as well that's doing the work. So we are spreading out the workload for the right people, but bringing it back together for a conversation. We also do a neighbourhood MDT once a week, and we will talk about 30 people in that meeting. And we talk probably about 80 people in the combined GP surgeries. And in our neighbourhood MDT, we are bringing together the surgeries with the community teams to get the right person to see the patient or person the first time. There's no referrals, there's no paper referrals. It's conversations where the surgeries speak directly to teams that could potentially then see the people for them. So we don't have to wait for a referral, for it to be the wrong referral to go back to the surgery, to then go to somebody else that could be the wrong person again. We have that conversation and we say, how can we help you? We don't say, sorry, it doesn't fit my pathway. And we don't say, no, and we will take people on and we will work with them and find the right people to work with. So that's making friends with people, not saying no, and actually being really positive. And I will always remember someone joining an MDT, and it was their first MDT, and they said, send me a referral. And everyone looked at her and she went, oh, we don't do referrals in this group, do we? And it was like, no, we don't. So there is learning for new people coming in. But those MDTs are important because they are the bedrock, and they show people what we can do, and they show people we can empower people and take people for the GPs and look after them in a holistic way, and then go and do a holistic assessment. So these are the people that GPs may be saying, I wish I had more than 10 or 15 minutes to sort this patient out in their entirety. I wish I could meet with their family. I wish I could get maybe the Parkinson's specialist nurse involved. We can do all of that. And quite often in a huddle, because of the relationships we build up, looking at the people that we need to look after, we can have an answer from the Parkinson's specialist nurse by the time we finish the meeting for the GP surgery. So we do meet with the Parkinson's specialist nurse. I put them on specifically because that's one of our patient cohorts that we can have a big difference with. And we meet with the Parkinson's nurse once a month. We see people for her, she sees people for us. We talk to each other about prescribing. We get really fast outcomes for people in the community. Can I have the next slide, please? So I put my hexagons up because I believe that people, if we talk about older people, potentially with frailty or with dementia, people enter our system at any point in that outside circle of hexagons. So they may come through adult social care wanting a referral for extra care and support. They may come through mental health services with memory problems. The pharmacy or the community pharmacist may have picked them up because they have got medicines returned to them that they're not taking. GPs may be concerned. They may have been sent to a falls clinic in rehab. There may be housing issues. And these are the people that we need to be supporting holistically. So we need to have some sort of way, which the neighbourhood provides, of grouping that person into her holistic assessment to look at all their needs. Because people aren't just a social problem. They're not just dementia. They're a person with needs and a family and sometimes a wife or a husband. And we need to look at the bigger picture. So an example of that may be somebody who may have swollen legs, who's not taking their medication and their legs are breaking down. And we've got a district nurse, so a therapist or a district nurse going into their house. Actually, if you look, you may find that they're not taking their medication. And it may be they're not taking their medication because they don't want to. It may be they're not taking their medication because they don't remember to. So we need to look and work and look at their medical issues and their memory problems and have that big whole picture and not prescribe for an illness, but prescribe for the person with the illness. We need to make it about people and what matters to them, how they feel, and what's important to them. So I will often say to people when I go into their homes, when I introduce myself, I've come to see you. I'm a GP who works with your surgery. I am going to look at the whole of you, not just a bit of you. I'm going to see how that's impacting on your husband or your wife or your carers. I'd like to involve your family. I will say I'm not taking you away from your surgery because people like that routing in their surgery. I'm not here to do things to you. I'm here to do things with you. And I'm not here to put you in a home, is what I also say, because people worry that I've gone in to do something to them that they might not want. And that's something about the language. We used to introduce ourselves as the complex care team. One person once said to me they had 15 teams involved in their care, and they couldn't remember them all. And what we've learned is that people identify best with your profession. So that's why I say I'm a GP. I'm a GP in the community team, and that's all they really want to know. They don't want to know which specific part of the team I'm with. They want to know what my credentials are and just generally who I'm working with. Can I have the next slide, please, Fran? So this is what we do with people when we go into their homes. So I just missed the population bit out to begin with. We do a comprehensive assessment. I put geriatric in brackets because they're not all older people. Comprehensive geriatric assessments for people who don't know what they are. It's a holistic assessment. So we look at people's medical needs, their medication. We look at how they're functioning, so how they're managing to walk, how they are managing to get their food. We look at their social situation. We look at their environment, and we also look at their mood and their cognition. So it's a whole picture, it's the whole thing, and it's evidence-based to be a robust tool that we can use to then give us information to produce a care plan for someone. So we will then do that care plan, and we will make sure that it's in the right place that people can access it. There's something about care coordination and continuity here. The system is complex. People aren't. And we need to make sure that we simplify things for people, whether that's appointments, whether that's getting in contact with people. And having a care coordinator can be priceless for people trying to navigate our system at the moment. And in where we work, it doesn't really matter who the care coordinator is. It may be me as a GP. We do have people who are called care coordinators, but I think there's something about who is the main person that knows that person or patient, working with that person, who the person trusts. So that's how we would do the care coordination where we are. And we would always, if we need to, talk at our MDTs about these people as well. So it's brought back to the group, we share the risk. So the population, a lot of people are interested in population metrics at the moment. We, as I've described to you, we get our patients, people from all different sources. We can use artificial intelligence, and a lot of places are using artificial intelligence. But I would say we can use our own intelligence as well. And we can pick out criteria of people who are most likely to be whatever group you want them to be. And I think for me, it's looking at people where we can make the biggest impact for lives and then help the system. And I think one of the unique things about my role is I work across all the organisations. So I can go into a hospital if I want, and I can go and do a capacity assessment with social care on the ward. I can go and support my patient and their carers on the ward. I can work with the community teams. I can go and present patients at the dementia assessment service meetings to reduce steps. So we as a team can work fluidly across those organisations. We work very closely with the discharge team in the hospital through our team. And those bonds and links are really important to get it right for people. We need to almost forget, this might sound controversial, the buildings that people are in, but think about the person and the teams that they need as opposed to where they're residing. So the population is also important in the community. One of the other meetings that I do is I meet with each of our neighbourhood teams once a month, and we will meet with the clinical director for the GP surgery, we will meet with the council, we will meet with our neighbourhood development manager, and people who are trying to get it right for the community. So we will look at what our population needs, and that may be a bus route. And I have no problems trying to help sort a bus route out. Being a GP, I don't see that not my role. I see my role in the position I'm in as trying to work out what my population needs, what relationships I need to build for people, and making friends with those people that I need to support the populations that I'm looking after. And that's how we drive the change. Next slide, please. So that was the simple bit. This is how we got to success. So it was a stepwise process. So I don't know if there's anyone on the call here who was originally in the vanguard with me. But the Vanguard was actually started a year before I joined it. I joined in 2016. The Vanguard project is a new model of care linking primary care and secondary care. So at that point in time in 2016, we worked with GP surgeries, which was enhanced primary care, which means a huddle or an MDT. So that was set up and sort of given to us with health coaches, which are social link workers, and complex care team. So the teams were put in place, and we then looked to see how we could make a difference. And it soon became apparent that it wasn't necessarily people with 2 or 3 long-term conditions, but it was people who were involved in multiple services, that we could work together, talk together, bring our shared knowledge together, because we learn from the other organisations that we work with, that we could support our community best with. So that's how we set up. I write employer there again initially, because initially I wasn't employed by a joint organisation. I am now. And I think there's something interesting about permission as we go forward with neighbourhood working. Employing someone who is, so I'm employed by the Integrated Care Board and then through the trust, but having someone employed by that works across all organisation is an interesting concept, because you do have permission to go into other people's spaces, although we did do that before that. We did a pilot with the Alzheimer's support workers, and we do all now in each neighbourhood have an Alzheimer's support worker. They join our neighbourhood huddle, and they absolutely are the most amazing people to support post-diagnostic people with dementia and their families. And living in a rural area, they are key to that work. And everywhere will be different, but in our population, they are absolutely key. We received recurrent funding from not from the Vanguard, but from our CCG back in 2019, and we extended to a 4th primary care network at that point. Our links with social care started being developed in 2021, and we had a 12-week pilot with a social worker in our office 1 day a week, and we got our wait list down from several hundred days to not very many days quite quickly by joint working, by conversations, trusting each other, relationships, making friends, and supporting each other. So working in the community can be, it's a big place out there, and we have lots of people doing jobs individually. And I will always remember coming across some of the voluntary agents, and they would say, oh, we've been in Morrison's car park having a coffee and using the toilet. And I would say, oh, there's an office here, there's a toilet here, there's biscuits and coffee. So we always make sure that there's coffee and a toilet, and everyone is welcome who's working in the community. And I suppose it might be a bit of a bribe, but that's how we make friends, and that's how we support people. Because if people are running into difficulties, they know that there is a place, call it what you like, hub, for them to come to be looked after, to help get advice with the people in the community. Prescribing is a big thing for me. We did a project called Show Me Your Meds, where we have asked community teams on routine home visits to simply look at patients' medication, people's medication. And we found that 1 in 4 of the people we looked at had excess medication in their home that they hadn't taken. And I think we found over 1,000 months of prescription items in the first 3 months that hadn't been taken. The WHO estimates 1 in 2 people don't take their medicines as prescribed, but we were finding 1 in 4 weren't taking sort of large amounts of medicines, 3 to 6 months. We found 2 years of insulin in someone's home. It's big amounts of medication, which is a bit of a red flag for how we can support these people. But it's a tangible metric as well. It's a tangible thing that people can see, and people like to be able to find something that they feel they're making a difference with. And then that's a conversation with the person and the family as to how we sort that out. Our trusts merged, I think it's 2023. If there's anyone here from the trust, I apologise if I've got the date slightly wrong. We changed our name from complex care, as I described, so we don't call ourselves complex care anymore. We call ourselves, I'm part of the complex care team, but to patients, people, I'm part of the neighbourhood team. It's simpler. We do need to think about the language we use for people and patients. We blend our team working, so if I'm out at the far end of our patch, I will message the team and say, I'm 40 minutes away, have you got anything I can do with my skill set for the people that you're looking after while I'm out here? So it is a joint effort. How do we work together? currently, at the moment, some of the things that we're doing are the Adult Social Care Hub Days. We had a day in a sports centre where we brought people in to do that one-stop shop with people. And my vision, my hope would be that we can take that around GP surgeries. So we're building relationships not only for patients, people, but making it easy, close to home, but we're also building relationships in the wider teams. We have deep dive discussions from the hospital before people are discharged with community teams. It is amazing. We get an email that comes through, an automatic link when the people we know are being discharged, so we can plan and make it better and then follow people up. So there's a good step up and step down. We are proactive and we're reactive. And I mentioned the services with dementia that we're trying to support and make things better for people at the moment. Have the next slide, please. This is my last slide, you'll be pleased to know. Thank you. So I'm going to just give you 2 seconds to read that middle bit, because I saw this on LinkedIn and thought it really described well what we do. So what does success look like for me? Success is when I hear people around me say, how can I help? Rather than no. It's positive impact for people, patients. It's people wanting to come to work. One of my F2s once said to me she never had that Sunday evening feeling. She enjoys coming to work. And we are dealing with people with lots of things that can be challenging, but we enjoy trying to sort that out as a group and looking after people together. It's staff of identifying around a community as opposed to not necessarily their employers. And it's reducing steps in patients, people's pathways. The more we can get that right for people, the better we can make the system work or flow. I know that's a contentious word sometimes, for people and staff and the whole system. And I think that's how we make a difference to people's care in neighbourhood working. Thank you. Mohit, I can't hear you. I think you're on mute. Sorry.
Golly, all those golden words of mine lost. When we were at about half past the hour, I wanted to give you a reminder, but it was so thrilling what you were saying. You get sucked into it, and I just didn't want to stop because the flow was beautiful and the story you said was so beautifully articulated. You can actually see live people in front of your eyes with separate kind of issues being supported in a way that makes them feel they are stronger to deal with their condition. That confidence that matters more for people than merely being told, here's your insulin, and that's what you'll require for diabetes. So it's brilliant. And as you can imagine, there are tons and tons of questions that have already started coming, which is brilliant about this. So a couple of questions to start with. I mean, loads of people saying good evening to each other, and thank you for that, Keith, especially to you, old friends. I can see in this. There's a very good question raised. So there's a question raised about infrastructure, and nationally, there's a lot of talk right now that 25% of primary care infrastructure is not fit for purpose is the wrong term because that makes it sound like people are working in horrible places, but it is not the best and it doesn't give the ability to grow. And a lot of what you're talking about is without a doubt about relationships, but relationships only work when people are close to each other. You see each other, the white of the eyes. Doing this on the web is never the same as feeling it and having a conversation about how's your kid, how was the exam yesterday, what happened, and then you reach a level of maturity that you can ring someone when you're 40 kilometers away to say, I'm at this end of town. Is there someone else you want me to see? Rather than you having to come down, which is exactly the story you said. So what was the mechanism, or what did you find both either as an enabler or as a stumbling block to make that work in terms of physical assets that allowed it to work? The building, getting teams together, the space.
So initially, right at the very beginning of the Vanguard, they were based at the hospital. So when I joined the service, we found ourselves a room in the community hospital. And it's really interesting because it was upstairs by the nurses' station at the far side of the ward. And the district nurses weren't in the building at that point. And the person that was in the building was the older person's mental health community psychiatric nurse, and he lived downstairs. So, again, if there's anyone on this call that is from my trust, we moved downstairs and we would seek forgiveness afterwards to be with him. And then the district nurses moved in, and then the therapy teams moved in as well. And I think even a flight of stairs makes a difference. And that might sound odd, but if we could knock the walls down where we are, we would. So I talked about working on relationships. We will move ourselves around the rooms. We will on an MDT, we will make sure we involve everybody. So we work at the people that we bring to discuss so everyone feels included. If somebody new joins our team, we will go to the surgeries. We will make sure that they've met people in person, and we will make sure that they feel confident to speak up and build those relationships. So you do have to work at it, and we will go into the surgeries for the MDTs as well. And if something, if you've had a particularly tricky case or they've got new people in the surgery, we will also make the effort to go in. But if we're in their patch as well, if you can imagine, we've got 5 different sort of small towns. If we're in their patch, we will go in and have a coffee or use their toilet as a way of thank you, that's helpful. And they see our faces and we can talk about the people so they know that we're around, and that builds those relationships as well. And they can come into our space as well. So there's always open, and we will make sure that we do invite them in, the health coaches and things, to our space. We'll do some education session or something. So it's very much about sharing generously and not worried about whose building it is. I'm allowed to use equipment from the GP surgeries, even though I'm not employed by them. I use their secretaries. Use is a harsh word. They offer to help me. So it's just sharing.
Fabulous. And I think it shows the power of relationships going beyond where constraints of buildings can start affecting those, because actually then buildings become important but secondary to the fact that people do not know where the boundaries exist. The building is no more a boundary, it belongs to everyone as a purpose.
Yeah.
And the purpose is to improve care, not to be my fiefdom. And so I think it's beautifully articulated and kind of goes back to the fact that if you can start at the nidus of start, I mean, you were very fortunate to be in a hospital, so the constraint of the size of the building didn't start at that point. So I think for colleagues who are on the call today and thinking, that seems brilliant, and I'd like to try something, do start with a site rather than just thinking my room and that's the only place that you can be. Start with a place that allows the flexibility. But as the relationships grow, the place will become secondary to that, because the relationships would allow other things to come into being, which allow the flexibility. So it's really beautifully articulated. And I think there's something someone's raised, which is really nice, which goes back to the point I was raising. In your experience, having done this for so long and being a pioneer nationally now, do you think this new trend of having remote MDTs on patient care, where you log on to MS Teams, and Deb, like me, I mean, I'd hate to say like me, but 36 years now, having been a doctor, I'm too old fashioned, too old school to want to do this on Teams. What's your experience? Do you think it's exactly the same, or do you think it does make a difference to have people look at the white of the eyes?
I think it makes a difference to have people look at the white of the eyes. Absolutely. But I think in this day and age, we can't do it all like that. And we wouldn't be able to bring the teams together all the time because of travel and distance. And maybe you can if you live in a smaller location and your PCN, primary care network, is in one place. But in a rural locality, we will have people on the road who will stop their car and join on the road. So it gives you more flexibility. And I think you do have to work at those relationships on an MDT, and how you work with your team and the language and the rules and the boundaries for an MDT. And there are rules that we have that, you don't do other work while you're sat in an MDT, and you focus. And there's something about introductions for people who you don't know. And you do build up relationships with people on virtual teams and you can read what they're thinking. I'm sure most people on this call will have experienced that. The people you know really well, you can second guess what they're thinking, and you can work together on an MDT. So, and that's quite special as well. But I absolutely, if we can get people in the room once a month or something like that, then we absolutely will. And going into the surgeries and sitting in their MDTs is also priceless for their team members. So yes, you never beat being in a space with people, do you?
I think you make a good point. Is around if you start by building those relationships and seeing the white of the eyes, there's the opportunity to use some online working,
Yeah.
not quite the same as trying it the other way around, build those relationships, because that does count. And I think there's something really great that someone's asked. Now that you've done this for some time, Deb, and you kind of know, how has this swung the pendulum about proactive care as opposed to reactive care?
So initially, we started off as a proactive service. I think as you develop your service, you realise that you know a large proportion of your population that are in a cohort that if they become unwell, you are the best person to respond to them because you know that person best, you know the family, you know the carers, and you can sort people out fairly quickly. So we do both. We can do proactive work on populations, as I explained. We do cohort work in our MDTs, and we can stratify that across the whole neighbourhood. So it's not just me. We can even start. We started to build relationships with children's teams as well. But I think it's really important, the reactive work, and I want to develop that further and develop further relationships. So we do some of the hospital at home work ourselves. But I think there's more we can do, and that's sort of the next step on that stepping stone of what we're going to try and achieve, I hope. And it's really interesting. So a few years ago, we ended up talking about being proactively reactive and reactively proactive. And what does it actually mean? You know, when am I being reactive, and what is our definition of reactive, and what is a crisis and what's a pre-crisis? And actually, people are still people, aren't they, at the end of the day? And someone said to me, "What's your pathway for delirium?" And I don't have a delirium pathway. I see a person. So they're still people. And if I have the capacity to go and see someone who I know, then I'll absolutely go and see them and sort them. So yesterday there was someone who was potentially might need to go into hospital. I went to see them and they didn't need to go into hospital. So, and that was like, they weren't far away from where I was based at that point in time. So, and I had what was really lovely was as I walked out the office, I had a district nurse and a therapist say to me, an occupational therapist said, "Deb, do you need us to come with you?" So I had two people on separate occasions, and that's that team culture. And I walk out the office thinking, if I'm in difficulty, I'm not by myself here. And I don't have to wait for the urgent care response teams or hospital at home. I have my own team who will respond reactively as well, even though we're not supposed to. But we can manage this and manage our community. So
And it's just so wonderful to hear that story, about someone who didn't have to go to hospital and got care outside. Because I know there are many colleagues in hierarchies who would think around that saves so much money, can be used better. And they're right. They're absolutely right. It's better use of resources. But more importantly, in terms of the lifespan of the person who didn't have to go into the hospital, evidence shows if it's an elderly person who's gone and they're more likely to go into long-term care, they're more likely to come back dependent on things and support. So effectively, you've made a difference. You made a difference to their carers who would have to run to hospitals, which disrupts everything else at home life. It's just such a rich experience, that intervention at the right time, at the right place, but someone with your expertise coming in, and then your colleagues chipping in also gives you that confidence. No, I've got a team around me supporting.
yeah, and I think the other thing we have to think about is if someone goes into a hospital who may not need to go into hospital, if we can solve the issues at home safely and appropriately, we could potentially then be causing a delay for discharge. That delay for discharge may mean that we have someone sat in a corridor waiting for a bed. That person sat in a corridor may mean that someone can't be offloaded from an ambulance. That person sat in an ambulance means that an ambulance may not be able to pick up, for example, my neighbour who was on the floor for 5 hours with a broken hip. So that's affecting the whole system. And that's what we need to keep an eye on, the big picture.
Absolutely, absolutely. I think some really good questions coming on as is getting hotter and hotter. There's a question about community organizations and charities playing a big role in working as a team around GPs and primary care colleagues. And from experience, of course, I've seen it happen. But there's an example of asking someone like the Stroke Association, and I've seen what they've done elsewhere. What's your view on that, Deborah?
Yeah, we use charities and organisations a lot. So motor neurone disease charities, Parkinson's, stroke charities, anything. Yes, absolutely. If they can support a person and that's the person's wishes. Yes, we work with Age UK a lot, as you can imagine. Planning for winter, map and chat from Age UK. So Age UK will link people in for people's houses to be looked at to make sure that they're winter ready, that their light bulbs are right, that their radiators are efficient and effective. So we will proactively look at people's environments as well. Very important with winter coming. So it's how can we make an effect now in the service, in the system, to support people to be winter ready is and so charity work for anything is absolutely really important. Yes.
Brilliant. Some wider colleagues about questions around, will the recording be available? Yes, colleagues, it'll be available. It's always available. If you look up, it's always uploaded on YouTube, and it adds another 500-600 hits by the time of most of the webinars that go out have about 3,500 hits by the end of a quarter. So you'll be able to see them. Questions around why can't we see others? I'm not sure how that's going to be helpful, but perhaps I'm just missing the point. Do please write out the question as to why that will be helpful to you, and I will have a thought about this. It is completely meaningless at this point, because what's more important is you can see the speaker and post your question for this. And you want to know how many people are there. As I told you, there are over 200 people who have registered on multiple platforms that we are available on. So I hope that gives you a feel of this webinar. There's a couple of really good questions that are asked. There's a colleague who is there in many of the webinars, so I recognize John's name, and really good one about, you know how this starts with, most often when you talk about QI, you talk about improvement. There's always this question around, that's on top of my day job. How am I going to find the time to do this? And while you are now at a point where you've turned the corner with people recognizing the value, and it's much easier for them to do it, how did you work around getting people with aligned values? Because I've never seen a clinician who doesn't want to improve care. They always want to improve a patient's outcomes, but helping them get to a point where they recognize this is actually going to make it easier to deliver care if it's done the right way. What did you have to do to get that vision signed up from everyone?
I think when the Vanguard started, the people who were involved were very passionate. And there was a great team around of people who were motivated, enthusiastic. And I think you then seek out people who are like-minded. We managed to show some good outcomes, reductions in bed length stay and things, which is how we progressed our service. I think every time you then do something different that shows a benefit, you have to talk about it, talk to people, show people the benefit of how it's working, tell patient stories. Be prepared to put your hand up and say, yes, I'll talk about this, which is not something that ever used to come easily to me, I will say. But for the last few years, I've been able to. And the reason I've been able to do that is by thinking about people, patients. So I talk about the service because I think it will make a difference to people and patients and the workforce. So you have, and it hasn't always worked. There've been some, pitfalls along the way, and you have to be resilient and pick yourself up and move on. But it's then reaching out, and I do talk to quite a few other GPs who are trying to set up frailty services. I talk to other ICBs, I have, I suppose, going into the NHS, taking other steps into other positions where you can share the work where you think it's going to be beneficial. Doing my medicines project, Show Me Your Meds, is a way of, I did that to show how we could evidence this way of working. So I suppose you could say I was strategically looking at ways to evidence what we were doing to then show into different organisations to then share what we were doing. And that's how people have heard about it. So spreading it and keep building, keep bringing people along, keep showing how it works. Simply.
Fabulous. And I think I'll have to take the pick now, given the number of questions, and we probably have time for one quick comment from you. And this is a colleague who has asked, how do you measure success? And you're at a point where you're very mature as an organization in terms of what you're delivering. What would be the top 2 or 3 indicators you would pick up, Deborah, to say this has been a successful outcome?
So I will still say success is a happy workforce. I would say success is, I would still absolutely say reducing waste in the NHS, and that can be time, that can be medicines, that can be reducing, not over medicalising people, supporting people. And I think the other success is education, supporting people in their education. And I'm a great believer in looking after other clinical specialties and supporting them, our OTs, our district nurses, medical students, trainee doctors, trainee nurses. We've always got someone normally in the car besides us. So I think that's a success, that people want to come and see what we're doing. And just the fact that I love my job, that's a success.
That is always a very big success criteria. And I think, Deb, I have to say, I've been hearing today so intently what you've shared, and the passion that flows out from you when you talk about it is so enthralling. It just kind of, grabs me, and I'm sure it grabbed many of our colleagues who are online today hearing you. And I think it was really fascinating to hear you describe your vision at the start, talk about putting that vision into practice, and see today as a doctor how you've influenced the practice of medicine into a life which is beyond years and decades. This is a way of working that will now span across for many to pick up for years and years to come. And hats off to you, Deborah. What you've shown today has been phenomenal. I mean, there's some snippets of what you said which I absolutely loved, and I was writing that down to say, people are not complex. It's about making systems simpler. And I love that sentence. I absolutely loved it. I was writing it down. You spoke about identifying not with the organizations you belong in, but identifying with the patients we serve and the people we serve. You spoke about finding the right people to support the care that's required and not getting stuck in it being medical and not my problem, or clinical and nursing and not my problem. That example of getting a ticket for your patient who wanted it being important to them, and that's what mattered. And what I really liked was the principle on which primary care is built is about continuity of care. So not only have you found a way of working around some very complex cases without being patriarchal about this is my territory, you've actually managed to keep continuity of care by creating that role of a care coordinator, which is agnostic to the skill set the person has, but is actually intrinsic to the requirements of what the service user needs. And that is just phenomenal. And it was just so powerful to hear you actually articulate that vision and lead it and successfully complete it. And there are so many patients and families and clinicians in Somerset who would be looking at you and saying, thank you. And I think many of us much wider today are going to say the same thank you to you for this evening. It has been a most phenomenal evening hearing you share your vision. I think colleagues, for many of you who have logged on, and over 200 of you to respond to that colleague who wants to know how many people are there. Well, there are over 200 of you in different platforms. I can never say enough of a thank you to you all, because this is only meaningful, all this effort to go out and create this webinar and to invite guests and talk to them and create the script of what we will have a discussion about. without you taking such an active interest. So I'm incredibly grateful for the support and love I've had from many of you, including Jamu, who's told me I look now older than her, which thank you, Jamu. Finally, I look my age, and I'm pleased about that. I think um, for those of you, I would be very grateful if you take a moment to use the QR code that has been put up in the box by my colleagues to comment and give us your feedback on this webinar so that we can keep improving and taking back your feedback to make that part and parcel of how we respond. And a heartfelt thank you to two people without who Deb and I would be lost completely, both Fran and Sophie, who in the background, so quietly and mystically, like magic creatures, make it all sound brilliantly easy. But believe me, I'm an absolute Luddite when it comes to digital stuff, and they make it happen. So a big thank you to Fran and Sophie in the background who do this amazing job for you. Colleagues, next month, I have another GP, an amazing GP, who is now leading the implementation of the new model of GP contracts. And they are trialing something out. So we will be hearing from him on the reflections and learnings from that work that he's been doing. Deborah, a big thank you to you again.
Thank you
It's
for having
been
me.